I'm Jerry Hesch of the Hesch Institute in Aurora, Colorado, and developer of the Hesch method of treating sacroiliac joint dysfunction. This presentation is titled, Why is the Muscle Energy Treatment Model, also called MET, so ineffective in resolving sacroiliac joint dysfunction? I have 18 reasons to present to you. Number one, the muscle energy model is based on a 1958 osteopathic biomechanical model, meaning the model describes how supposedly movement in the SI joint and pubic joints happen, and that model has not been updated. So if you get treatment from someone trained in muscle energy, they're based on that 1958 biomechanical model. We've learned much since then. Number two, in that traditional model, they describe an upper pubic rotation, a backward rotation of the pubic bone, and that simply doesn't exist. And that's based on palpation and passive motion testing of the joint. It doesn't exist. Number three, it uses pubic popping as a so-called pubic joint adjustment. Now, I understand that that may feel good for a little while, but you'll notice it never lasts. People who do pubic popping have to do it repeatedly. Well, the popping noise can actually be the adductor longus muscle creating a negative pressure of the tendon within the tendon sheath. And again, it may feel better temporarily, and maybe even your low back, your pelvic area feels better, but it doesn't last. Okay? The pubic joint is such a strong structure, except in rare instances, and it takes 3 to 5 minutes to get that bone to actually move. And so in my model, I use a fulcrum to move it, and I spend 5 minutes getting that structure to move when it is displaced. Number four, MET describes a so-called unilateral flexion dysfunction of the sacrum and a unilateral extension dysfunction of the sacrum. There's no such thing. That doesn't exist. If you use additional palpation of the sacrum with the body in flexion, extension, and neutral, and you do spring tests throughout the sacrum, passive motion tests, there's no such thing as that. Okay. Some of the descriptions of pelvic movement are accurate in that model. So we don't completely throw away that biomechanical model, but we build on it. Number five, the MET model only teaches a few self-treatments. There's a large number of ways the pelvis moves, but there's only a couple of self-treatment models to supposedly adjust or align the pelvis. And so the MET model makes the patient dependent on the practitioner to do adjustments to them. Again, that does not provide lasting relief. Reason number six, the self-treatment to align the pelvis for an anterior or posterior ilium is done by hugging the knee straight up, pushing into the knee for 10 seconds, relaxing, stretching it up. Now, I realize that this will stretch the opposite hip flexor muscle, and it's done on both sides. But the force actually compresses the sacroiliac joint. It does not induce posterior rotation movement of the ilium. It doesn't capture the plane of the SI joint. And when someone has a twisted pelvis, and I say entire pelvis being twisted on the hip joints, in which we find an anterior ilium on the right ilium lower than the left, that can be the entire pelvis moving with the spine, with the trunk, and with the hips. With that pattern, a better way of aligning the pelvis and restoring normal movement through that structure is to hug the knee outside of the shoulder. So that's done at about a 20-degree outward angle. All right, number seven, MET does not evaluate motion in the SI joint. Okay? So when someone is sitting and they bend forward and the practitioner is feeling your PSIS's move, okay, looking for symmetry or asymmetry, or when you're laying down and you sit up and they look and see if your leg length changes, or you stand and you bend forward and they palpate the PSIS's in the sacrum, or you stand and you lift up one leg down and then the other leg. Those are gross movement tests. There are so many muscles that are involved with that joint. And the one when you stand and lift your leg up, you could have asymmetrical motion in your knee joint just based on developmental differences. Same for the hip joint, same for the foot and ankle. You could have differences in muscle facilitation one side to the other that would cause the pelvis to move asymmetrically. Or you may have a true leg length difference or an asymmetrical development of the pelvis. And MET does not take those things into consideration. The testing that I use to evaluate micromotion, because the SI only moves a very small amount even in people who have been injured, and this has been thoroughly researched. This is a very strong joint, only rotates about 2 degrees, and in a full circle you have 360 degrees of rotation. So it rotates the smallest amount and it glides about 2 millimeters. And so my fingernails are defining what 2 millimeters is. Extremely small amount of motion. The method that I use and have developed, and another group of clinicians also developed this around the same time, and that is using passive motion testing, which I call spring recoil testing through the joint. And that is a way to evaluate whether or not movement translates through the joint. Okay? And you can find more information on that going to YouTube and typing in my last name and spring test. My last name is spelled H-E, S like Sam, C-H. Number 8, MET does not account for a treatable hypomobility or a treatable hypermobility in a pelvis that is already symmetrical or aligned. So you can go to YouTube, type in my name, and type in symmetrical sacroiliac joint dysfunction, or search for a posterior glide sacral fixation. And this is a person whose pelvis is completely symmetrical, and yet they have motion dysfunction in the pelvis based on the passive spring testing. When the sacrum is stuck posteriorly, which happens with delivering a large baby or falling on your buttocks, it gets wedged, and all passive motion throughout the pelvis and sacroiliac and pubic joint is lost. It's easily treatable. I developed a treatment technique for that. But again, we have to evaluate these micro motions, because you can have a symmetrical pelvis that has too little motion that's treatable, or it can also have too much motion, and that's also treatable. Number 9, again, it also does not evaluate true hypermobility. Passive motion testing is one way of evaluating hypermobility, and there are subtler forms where someone may have a symmetrical pelvis and have hypermobility, and sometimes the testing is not subtle enough to discern that, but using a sacroiliac belt, especially worn down low at the level of the trochanters, gives them distinct relief, and so then that's an appropriate clinical conclusion. And of course there are people in which the pubic joint ruptures and separates, and that's a distinct instability measured on x-ray, and also x-ray with a passive spring test. But we're not talking about that population. We're speaking mostly of the ambulatory population. Question number 2, it does not evaluate true hypomobility. Question number 10, we already mentioned that. Number 11, it does not recognize the following patterns of pelvic, sacroiliac, and pubic joint dysfunction, and these are patterns that I discovered, so they are unique to the Hesch method of treating sacroiliac joint. And I will mention all of these models that the MET model does not evaluate for and does not treat. And that is number 1, pubic posterior glide fixation, that's a Hesch pattern. Pubic separation, that's orthopedic trauma pattern. SIJD instability, again an orthopedic model. Bilateral anterior ilium, described by Don Tigney. Pelvic side glide, described by Hesch. Forward bent sacrum found in the orthopedic manual therapy literature. A backward bent sacrum also found in the orthopedic manual therapy literature. Posterior glide of the sacrum described by myself. Anterior glide of the sacrum described by myself. Side bent ilium described by myself. Oblique upslip ilium and oblique downslip ilium described by myself. Downslip is described in the muscle energy model, but they state falsely that downslip ilium is common, but it self-corrects with gait, and that's absurd. That's just not true. Downslip is a horrible thing, very symptomatic. I have a wonderful case study at the bottom of my homepage at HeschInstitute.com, spelled H-E-S like Sam, C-H, institute.com. Go to the bottom and you'll see Jordan's story, and this was a kid who had downslip ilium. Also have other cases. You can search YouTube, Hesch downslip ilium. The angle of force transmission when you're walking does not parallel the angle of the SI joint, so it's impossible for walking to cause the ilium to move back up when it's stuck inferiorly. Okay? And then the other pattern that I described and developed treatment for is called a lower windswept pelvis, of which there are 6 individual patterns consisting of lower pube rotation, lateral left ischium, medial right ischium, laterally rotated left hemipelvis, internally rotated left ilium, externally rotated right ilium, and with that pattern is a side bent coccyx fixation. Okay? And the muscle energy model does not describe side bent coccyx and does not describe treatment thereof. Okay? Number 15, the muscle energy model describes single dysfunctions as though only one diagnosis is predicted, as opposed to the Hesch model, which describes predictable sequential group patterns of pelvic pubic, SIJ, hip and lumbar spine, faulty motion patterns. Okay? So by treating all components of an injury that involves up to 10 different individual patterns of motion dysfunction, the patient is much more apt to get better, rather than just saying, oh, you have an anterior ilium with an upslip or posterior ilium with an upslip, which is incredibly rare, almost never happens on the right side, but is a popular diagnosis in some regions of the country. So an example of an MET diagnosis would be anterior ilium or posterior ilium or inflare or outflare ilium, whereas in the Hesch model, one of the group patterns, of which there are several, I describe as the most common pattern of sacroiliac, of lumbopelvic hip motion dysfunction. And that includes, well, I'm not going to name off the 10 different individual motions. You can find that online. And then reason number 16 is that MET does recognize the fact that when you treat, does not recognize the fact that when you treat one pattern, okay, such as treating an anterior ilium, then another pattern might emerge that requires treatment. So after correcting an anterior ilium on the right, it is possible for the left ilium to then be stuck posteriorly, and it is possible for a pattern of a right inflare and a left outflare ilium to emerge. Okay, but the muscle energy doesn't understand that happens, that permutation occurs, whereas the Hesch model has identified many of those predictable patterns. And it doesn't always happen, but it's important to keep evaluating rather than just say the anterior ilium is now symmetrical or it's now moving better, so now we just exercise. That's not the right way to approach this complex structure that integrates movement of the entire pelvis, moving with the lumbar spine, moving with the hips. Item number 17, muscle energy technique is based on the false premise that asymmetry of the pelvis is due to the sacroiliac. Well, again, the sacroiliac moves so very little. It has so many muscular and ligamentous attachments, and even in most injury states, it only moves a little bit, such that visually you cannot see a 2 millimeter difference, a 2 degree of rotation difference. The asymmetry you see is a muscular phenomenon of the entire pelvis moving, again, with the trunk and lumbar spine and hips. It is the micro motion testing that will evaluate the function of that joint, which is force transmission, shock absorption, movement translating through it, okay? But asymmetry doesn't tell you about the function inside the SI joint. Number 18, MET is based on the false premise that gross motion tests evaluate SI joint motion, and they do not, and I know that that's repetitive. I said that earlier on the lecture. I used to teach a muscle energy course, taught it several times. I used to use muscle energy technique to the pelvis, and wherever I teach, the feedback I get from clinicians is that MET works for a little while, but it does not provide lasting benefit. I'm not saying don't use MET, it's, nothing wrong in using it, but just understand the limits of that model and understand that there are different treatment approaches that use a small force applied for a longer period of time. There's a whole different philosophy of looking at multiple movement dysfunctions rather than giving it a single diagnosis. I have lots of informative YouTube videos. Just type my last name and search sacroiliac or any specific type of so-called sacroiliac joint dysfunction, such as anterior ilium, posterior ilium, etc., and you'll find helpful videos. And again, this is presented by Jerry Hesch, myself, at Hesch Institute, a physical therapy outpatient clinic in Aurora, Colorado, where we specialize in not only treating sacroiliac joint dysfunction, but treating the whole body, treating joints from the toes to the nose. Thank you very much.